هذا الجميع.
Mohammed, do you know who is going to lead the meeting?
Dr. Osama. Dr. Osama will lead the meeting.
Sounds good.
Probably he's joining in a minute.
Yeah, sure. Do you see my screen?
Hello, everyone. Ramadan Kareem.
Hello.
Hello.
Ramadan Kareem. Hello.
الله أكرمك.
رمضان مبارك.
السلام عليكم.
Ramadan Mubarak. Hello, everyone. Hello, Osama. How are you?
Yeah, I'm fine. How are you? Good.
Very good. So we're gonna start. I think.
Okay.
So if you want to go ahead and lead the team, the meeting, that would be great.
Okay, sure. Is that clear now?
Yes.
Yeah. Ramadan Kareem, everyone. Today we are going to discuss infectious disease. It will cover by me and Dr. Mohammed Tijani. Mohammed Tijani will cover tuberculosis direct management, and Azza will cover Framingham, a heart association study. First, I'm going to present infectious disease. The objective of a study to know and understand factors that influence immune function in elderly people, and ways in which infectious disease may present atypically in older patients, and criteria for initiation antibiotic therapy for residents of long-term care facilities, and how to diagnose and manage infectious disease that are common in elderly. Topic covered today, predisposition to infection, general principles for diagnosis and management of infections, epidemiology, diagnosis and management of specific infectious syndromes, and fever of unknown origin. Consequences of infection, mortality and morbidity. Mortality infection is the major cause of death in older adult. And morbidity infection often exacerbate underlying illness or lead to hospitalization. Here we have a major causes of death in adult over 65 years. Infection is 40% of deaths, and all other causes are 60%. Age-related alteration in immune system. Immune response decline with age, a phenomenon known as immune synthesis. And the main feature are depressed T cell responses and depressed T cell macrophage interaction. The most marked deficient of immune system in elderly is drying and thinning of the skin and mucous membrane, poor antibody production, and decreased production of type 2 and T cell helper. Impact of comorbidity on immune function. The impact of comorbidity on innate immune function and host resistance is greater than impact of age itself. So we thought that age is the main feature, but the impact of comorbidity on the immune system is greater than the impact of age itself on the innate immune system. Comorbid disease also indirectly complicate infections, community-acquired pneumonia in elderly person with multiple comorbidity often require hospitalization. Impact of nutritional status on immune function. On hospital admission, global undernutrition is present in 30 to 60% of patients over 65. And 11% of older outpatients suffer from undernutrition, mostly due to reversible conditions such as depression, poor control diabetes mellitus, and medication side effects. Some nutritional interventions may boost immune function in older adult, but results vary with population studied and supplemented use. Atypical presentation. So, as you know, most of the clinical presentation in elderly population are not typical as in younger. So all adults may present without typical signs and symptoms, even if the infection is severe. So you cannot find like fever or some other serious symptoms on older population. Fever may be absent in 30 to 50% of frail older adult with a serious infection. Fever in elderly nursing home resident can be redefined as temperature more than 2 Fahrenheit over the baseline, or oral temperature more than 99 Fahrenheit or 37.2 Celsius on repeated measures, or rectal temperature more than 99.5 Fahrenheit, 37.5 Celsius on repeated measures. Antibiotic management. Drug distribution, metabolism, excretion, and interaction can be altered with age. As you know that the renal system will be affected most of the time in elderly, so the excretion will be slow. That's why the distribution, metabolism, and excretion will be changes. It is not like in younger. Even in the absence of disease, aging is associated with a reduction in renal function. Antibiotic interaction occur with many medication commonly prescribed for elderly people. Risk factor for poor adherence include poor cognitive function, impaired hearing or vision, multiple medication, and financial constraint. Suggested minimum criteria for initiation of antibiotic therapy in the long-term care setting. So we have condition and minimum criteria. For urinary tract infection without catheter, fever, and one of the following new or worsening urgency, frequency, suprapubic pain, gross hematuria, postophrenic angle tenderness, incontinence. So for diagnosis of urinary tract infection without catheter, just we need fever and one of the following. For urinary tract infection with catheter, fever or one of the following, new postophrenic angle tenderness, Rogers, new onset delirium. Skin and soft tissue infection, fever or one of the following, redness, tenderness, warmth, new or increasing swelling of affected site. For respiratory infections, fever more than 102 Fahrenheit and respiratory rate more than 25 or productive cough, fever more than 100 and less than 102, and respiratory rate more than 25, pulse rate more than 100, Rogers, and new onset delirium. So this is another criteria. If febrile, but with obstructive COPD, new or increased cough with virulent sputum. If febrile without COPD, new or increased cough and either respiratory rate more than 25 or new onset delirium. Fever without a source of infection, new onset delirium or Rogers. If antibiotic instituted as a diagnostic test, not recommended, discontinue in 3 to 5 days. If no improvement and evaluation negative, bacteremia and sepsis. Elderly patients with bacteremia are less likely than younger adults to have chills or sweating, and fever is commonly absent. GI and genitourinary sources of bacteremia are common than in young adults. Mortality rate with nosocomial gram-negative bacteremia, 5% to 35% in younger adult, and 37% to 50% in older patient. So mortality most commonly due to gram-negative bacteremia. Management of bacteremia and sepsis. It is similar in elder and younger patients. Rapid administration of antibiotic aimed at most likely source is essential. Early goal-directed therapy for volume resuscitation has proven benefit. In septic adult more than 75-year-old, adjunctive therapy with activated protein C has survival benefit despite a slightly increased risk of serious bleeding. Pneumonia, epidemiology. Patient aged more than 65 account for over 50% of cases of pneumonia. Cumulative 2 years risk for long-term care residence is absent in 30%. Mortality in elderly patient is 3 times to 5 times that of young adult. Comorbidity is the strongest independent predisposing factor of mortality. Here are the some organisms or causes of pneumonia. We have Streptococcus pneumoniae, atypical organism, Haemophilus influenza, Staph aureus, polymicrobial organism, and gram-negative. For community-acquired pneumonia, most of the organisms are atypical organisms. And for long-term care facilities, polymicrobial organisms constitute most of the causes. And in hospital-acquired pneumonia, gram-negative rod is the leading. Community-acquired pneumonia, Infectious Disease Society of America guidelines suggest that the following as first-line therapy for adult over 60 with or without comorbidity: beta-lactam, beta-lactamase combination, or advanced generation cephalosporin, such as ceftriaxone or cefotaxime, with or without macrolides. This is for community-acquired pneumonia. Alternatively, one of the newer fluoroquinolones with enhanced activity against strep pneumoniae, the new generation such as levofloxacillin, moxifloxacillin, and gemifloxacillin. Nursing home and hospital-acquired pneumonia. Initial regimen should be broadly inconclusive, followed by step-down therapy to narrower coverage if positive organism is identified. For methicillin-resistant Staph aureus colonized patient or patient in unit with high rate of methicillin-resistant, initial regimen should include vancomycin or linezolid until methicillin-resistant Staph aureus is excluded. Patient with improving hospital-acquired pneumonia not caused by non-fermenting gram-negative bacilli such as Pseudomonas, Trophomonas can receive short course of antibiotic for 8 days. Reducing the risk of pneumonia. There is many factors that reduce the risk of pneumonia in elder populations, such as immunization, smoking cessation, aggressive treatment of comorbidities, minimize aspiration risk in post-stroke patient, limited use of sedative hypnotics. Systemic changes with attention to infection control may be particularly effective in the nursing home. Influenza. Annual influenza vaccination is recommended for all adults over age of 50. Treatment with M2 inhibitor or neuroamidase inhibitor is the most effective if initiation within 24 hours of symptoms onset. Ostanfare is the easiest to use than Zamvanter inhaler. Older adults appear to be less susceptible to H1N1 pandemic of 2009, but are more likely to be hospitalized for H1N1 than younger adults. Urinary tract infection. One of the most commonest illness in elder. As in young adult, gram-negative bacilli are the most common organism. Older adults are more likely to have resistant isolate, such as Pseudomonas aeruginosa, gram-positive organisms, including enterococci, coagulase negative, staphylococci, and Streptococcus aeglesia. Additional organisms in patients with indwelling catheter include enterococci, Staph aureus, fungi, particularly Candida species. Asymptomatic bacteremia affect up to 15% of women in the community and 40% of women in nursing home. Incidence in men is approximately half that in women. Treatment is not recommended, no clinical benefit, associated with adverse effect, expenses, potential for selection of resistant organisms. Lower tract urinary tract infection or cystitis in older women, characterized by dysuria, frequency, and urgency. 3 to 7 days of therapy is sufficient for uncomplicated cystitis. Fluoroquinolone, more efficacious than trimethoprim sulfamethoxazole in recent trials. Sulfamethoxazole resistant usually more than 10 to 20%. So that's why fluoroquinolone is the first line. Option in some settings are amoxicillin, particularly for enterococcal infection, and first generation cephalosporin for patients with fluoroquinolone intolerance. Culture not required unless first line therapy fail. Our tract, urinary tract infection or pyelonephritis in older women, characterized by fever, chills, nausea, and flank pain, commonly accompanied by lower tract symptoms. It requires 7 to 21 days of therapy. Consider IV antibiotic for patients with suspected urosepsis and those with upper tract disease due to relatively resistant bacteria such as enterococci and those unable to tolerate oral medication. Culture and sensitivity data should be obtained in most cases. UTI in older men. Positive organism and treatment choices are similar to those for older women, usually due to obstructive prostatic disease or functional disability. More than 14 days of therapy is needed. If prostatitis is suspected, more than 6 weeks of therapy is usually required. Culture and sensitivity data should guide therapy for virtually all UTI in older men. Infective endocarditis. In the elderly population associated with degenerative vascular disorder and prosthetic valve, age does not increase mortality risk. Treatment is IV antibiotic for 2 to 6 weeks. Consider surgery for severe valvular dysfunction, recurrent emboli, marked heart failure, myocardial abscess, fungal endocarditis, or failure of antibiotic to sterilize blood culture. American Heart Association guidelines for endocarditis prophylaxis. Cardiac condition required prophylaxis, prosthetic cardiac valve, previous infective endocarditis, cardiac transplant recipient with cardiac valvopathy, unrelated cyanotic congenital, unrepaired cyanotic congenital heart disease, repaired congenital heart disease with residual defect at the site or adjacent to the site of prosthetic patch or device. Congenital heart disease, completely repaired with prosthetic material or devices, prophylaxis needed for only the first 6 months after repair procedure. Procedure warranting prophylaxis only in patients with cardiac conditions listed on previous slide. Dental procedure requiring manipulation of gingival tissue, manipulation of the periapical region of the teeth, or perforation of the oral mucosa includes extraction, implant, re-implant, root canal treatment, teeth cleaning during which bleeding is expected. In invasive procedure of respiratory tract involving incision or biopsy of respiratory tract mucosa. Surgical procedure involving infected skin structure, or musculoskeletal tissue. Procedure does not warranting prophylaxis. All dental procedure not listed on previous slide. All non-invasive respiratory procedures, and all gastrointestinal and genitourinary procedure. Endocarditis prophylaxis regimen situation, and we have the regimen single dose 30 to 60 minutes before procedures. Oral amoxicillin 2 gram. If unable to take oral penicillin, oral medication, ampicillin 2 gram or cefazolin 1 gram or ceftriaxone 1 gram IM or IV. If there is allergic to penicillin or ampicillin, cephalosporin 2 grams, clindamycin 600 milligram, azithromycin 500 milligram or clarithromycin 500 milligram per oral. If allergic to penicillin or ampicillin and unable to take oral medication, here we give cefazolin 1 gram or ceftriaxone 1 gram or clindamycin 600 milligram IV or IM. Prosthetic devices infection. Device removal usually required for cure. Elderly and prolonged antibiotic intervention for months combined with aggressive surgical drainage may be successful if symptoms have been present only for brief duration. When full functionality is the goal, the best course is device removal and administration of antibiotic for 6 to 8 weeks, followed by re-implantation. Administration of prophylaxis antibiotic other than for heart valve remain controversial. Septic arthritis. It is more likely in joint with underlying pathology. Early arthrocentesis is indicated in any mono or oligo-articular syndromes to exclude infection. Staph aureus is the most likely pathogen. Aggressive antibiotic therapy should be combined with serial arthrocentesis in uncomplicated cases. Surgical drainage required when conservative management fail. Osteomyelitis. Also, Staph aureus is a predominant organism. GI and genitourinary flora are more common than in young adult, so specific microbiological diagnosis is useful. Infection of pressure ulcer and diabetic foot infection commonly require surgical consultation plus aggressive antimicrobial therapy aimed at mixed aerobic and anaerobic bacteria. HIV infection and AIDS. Heterosexual activity is the primary mode of infection in older adult. Untreated older adult progressive to AIDS more rapidly than young adult, but response to heart is similar. Management is similar to that used for younger adult, except that more aggressive cardiovascular prevention is warranted. HIV is probably the most treatable infectious cause of dementia and much more likely to reverse with therapy than syphilis, which is more commonly tested. Bacterial meningitis. Older adult account for most meningitis-associated facilities. Ceftriaxone, cefotaxime, plus vancomycin are recommended as empiric therapy until specific isolate organism can be tested for antimicrobial susceptibility. Ampicillin is the drug of choice for Listeria species. More resistant gram-negative rods, such as Pseudomonas, require ceftazidime or an extended spectrum penicillin with or without intrathecal aminoglycoside therapy. Neurosyphilis. Possible underlying process in stroke or dementia, also considered in unilateral deafness, gait disturbance, uveitis, and optic neuritis. Positive CSF serology, VDRL test may be diagnostic, but the sensitivity is only 75% in most series. Optimal treatment is penicillin G. reactive varicella zoster virus, herpes zoster, and shingles. Advancing age is a major risk factor for zoster, for varicella zoster and herpes zoster. The most disabling complication, post-herpetic neuralgia, is the common in older adults. Zoster vaccine is recommended for all immunocompetent adults more than 60 years old, and this reduces the risk of zoster and post-herpetic neuralgia by more than 50%. Facial nerve palsy or Bell's palsy associated with at least 3 infectious causes: herpes simplex virus, varicella zoster, Borrelia burgdorferi, which cause Lyme disease. If facial nerve palsy occur as part of an episode of varicella zoster virus, antiviral treatment is indicated and corticosteroid should be administered as well. If Lyme disease is suspected on clinical basis, we give oral amoxicillin 500 milligram 4 times per day for 14 days, or oral doxycycline 100 milligram twice a day for 14 days, or IV ceftriaxone 2 gram per day for 14 days. Gastrointestinal infection can present diagnostic dilemma in the absence of fever or elevated white cell count. High index of suspicion is necessary. Diagnostic aids: intra-abdominal infection, CT, or labeled white cell study. Cholecystitis, appendicitis, abscess, we do ultrasound. If we suspect ischemic bowel, often require angiography or flexible sigmoidoscopy. Treat infectious diarrhea as in young adult. Clostridium difficile. A recent increase in incidence and severity, especially in older adults. First line treatment, metronidazole in mid to moderate disease, vancomycin in severe diseases. Relapse is more common in older adults and may require tapering the vancomycin dose. Prevention: reduce unneeded antibiotic and duration of needed antibiotic use. Fever of unknown origin, defined as a temperature more than 38.3 Fahrenheit centigrade or 101 Fahrenheit for at least 3 weeks, and diagnosed after 1 week of medical evaluation. And it is about 35% of cases are due to treatable infection, especially intra-abdominal abscess, bacterial endocarditis, and tuberculosis. Collagen vascular disease are more common causes than in younger patients, about 30% of cases. Neoplastic disease account for another 20% of cases. Evaluating fever of unknown origin in older adult. Confirm fever first. Contact through history include travel, MTB exposure, drugs, constitutional symptoms, symptoms of giant cell arthritis, and physical examination. Discontinue non-essential medication. Initial lab evaluation, CBC with differential, liver enzymes, ESR, blood culture 3 times, BBD skin testing, TSH, anti-nuclear antibody, consider anti-neutrophil cytoplasmic antibody or HIV antibody testing. Chest or abdomen or pelvic CT if no obvious source, or temporal artery biopsy if symptoms or signs are consistent with giant cell arteritis or polymyalgia rheumatica and increased ESR, or site-directed workup on basis of symptoms or lab abnormalities or both. Evaluating fever of unknown origin, continue. If 3A is performed and no source is found, then 3B and vice versa. If you go back, we can find A, B, C, D, 1 and 2 and 3. If it is not, if 3A is performed and no source is found, then 3B and vice versa. Bone marrow biopsy yield best if hemogram abnormal, sent for H&E, specific strain and culture. Liver biopsy, very poor yield unless abnormal liver enzymes or hepatomegaly. Indium 111 label with white cell count or gallium 67 scan, nuclear scan can effectively exclude infectious causes of fever of unknown origin if negative. Laparoscopy or exploratory laparotomy. Empiric trials typically reverse for anti-tuberculosis therapy in rapidly declining host or high suspicious for tuberculosis, prior positive PPD. In summary, immune function and host resistance are compromised in elderly people as a consequence of both immune conscience and comorbid disease. A redefinition of fever should be considered in the frail older patient. There are suggested criteria for initiating antibiotic therapy in residents of long-term care facilities. Careful selection of first-line therapy is warranted in older patients with pneumonia. Yeah, we have 3 quiz. Just we need you to be like interactive. I'm going to read the case and I need your response. We have a 79-year-old man in assisted living facilities has a cough, shortness of breath, and pleuritic chest pain. He has a history of heart failure with bivesicular block and chronic kidney disease with baseline creatinine of 1.8. His medication are lisinopril and furosemide and simvastatin. On examination, he is awake and alert. Respiratory rate is 22 breaths per minute. Temperature 39.2. Heart rate is 90 and blood pressure is 130/80. Chest auscultation revealed crackles in the left lower lobe. Chest radiograph show infiltrate community-acquired pneumonia is diagnosed, and the patient is admitted to the hospital. His creatinine is now 3.5 with an estimated creatinine clearance of 20 ml per minute. Sputum for gram stain is not obtainable. Urine for strep pneumonia and Legionella antigen is sent. Which of the following is the most appropriate initial antibiotic of choice? Moxifloxacillin 200 milligram, ceftriaxone 1 gram plus azithromycin 500 milligram a day, levofloxacillin, aztreonam 2 gram 3 times a day, plus vancomycin 1 gram 2 times, once. Anyone share the answer? Yes, the diagnosis is community-acquired pneumonia. So the treatment for community-acquired pneumonia is ceftriaxone 1 gram plus azithromycin. As we said, third-generation cephalosporin plus macrolides. 78-year-old man come to the office because he volunteering at the local hospital and is required to get tuberculin test annually. BBD using 5 tuberculin unit was done a year ago when he started volunteering. At that time, the test was read as 4 milliliter of induration and interpreted as negative. On retesting now, there is 16 millimeter of induration. He has no symptoms. Chest radiograph is negative, and he is on warfarin for atrial fibrillation, but has no other problems and has no other medications. What is the most appropriate next step in the management? So here you can say this patient is like just tuberculin, BBD is positive and there is no any finding. So are you going to, for observation only, annual chest radiograph, repeated BBD testing in 6 months, treatment with pyrimethamine plus rifampicin for 2 months, treatment with INH for 9 months. So here's the answer is INH for 9 months. Case number 3, 72-year-old man is seen for preoperative assessment in anticipation of a prostate biopsy. And he has asymptomatic aortic stenosis with stable type 3 to 4 holosystenic murmur and type 2 diabetes mellitus controlled by diet. And he is allergic to penicillin, but has taken cephalosporin and clindamycin for dental procedure in the past without any difficulties. Which of the following is the most appropriate recommendation regarding endocarditis prophylaxis for the biopsy? No prophylaxis, oral cefalexin, IV cefazolin, oral cefalexin plus oral clindamycin, IV cefazolin plus IV clindamycin. Just he had asymptomatic aortic stenosis with stable type 3 murmur and he had type 2 diabetes mellitus. So his answer will be no any prophylaxis is needed. And thank you for all. If anyone had any question, please unmute yourself and you can ask any questions. Any questions? Any comment?
Thank you so much, Dr. Osama. This is really great, and we really appreciate your effort. And it's very concise, very informative, and hopefully it will help us when we start the residency, when we see patients, and definitely you will find this useful when you come across patients with infectious conditions like TB or common condition like pneumonia and so forth, UTI. Thank you.
Welcome.
So maybe we can go to the next section of the meeting.
All right. The next part of this infectious disease is Dr. Mohammed Tijani. He will present a brief treatment of tuberculosis, direct observed management of tuberculosis.
السلام عليكم everyone. الحمد لله رمضان كريم. تفطر على خير إن شاء الله. Let me just share my screen here. Dr. Osama, can you let me share my screen? Right, so my presentation will be tuberculosis and adults as an example of treating tuberculosis in the developing countries. Meanwhile, I'll try also to compare the screening treatment options in the United States or developed countries versus the developing countries. First, we're going to start with just TB, a key fact about tuberculosis, which is a lot of, unfortunately, TBs remain as one of the still neglectable serious diseases all over the globe. One probably would be shocked by these numbers that I'm presenting today. And these are data collected or presented by the WHO by the year of 2020. A total of 1.5 million people died from TB alone in the year of 2020, and almost 1/4 of this number here of 1.5 million, or somewhere close to that, talking about 214,000 cases of HIV die because of the TB. Another kind of shocking news that TB is the second leading infectious killer after COVID-19, and it's still even ranking way high above the HIV and the AIDS, yet still one of the kind of still neglectable diseases, especially in the developing countries. In the years 2020, estimated 10 million people got sick with the disease, with TB, and out of this number here, unfortunately, 1.1 million children get sick or infected with the TB in the year of 2020. Unfortunately, especially with children or kids, children at TB, most of the times overlooked by care providers and would be unfortunately misdiagnosed. And that's very serious because you're talking about a carrier or active case of TB, basically walking in the community, playing with the other kids, spreading the disease among the close contact in the family or even in the neighborhood. Another kind of important data that we need to keep in mind here when it comes to the TB, that in the year of 2020, in 30 countries, most of the cases, the bulk of the cases, almost 86% of the new cases originating from 30 countries. Out of these 30 countries, at least 2/3 of these cases are located in these 8 countries. India would be number 1, China second, Indonesia third, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. And here, this map kind of shows the distribution of the disease in countries that never come to your mind that TB can be an endemic problem there, for example, China and India. But what we can take from this, basically, TB is everywhere, and definitely it's a problem, need to be addressed appropriately, and otherwise it's a very serious killer. As I just mentioned, it's a second ranking killer after COVID-19, the year of 2020. Another very serious problem comes with the TB, that multi-drug resistance, or multi-drug resistance acid-fast bacilli here remain a public health crisis and health security threat, as long as this microorganism can resist the available antibiotic treatment. Definitely it can survive. And as we all know, that this disease is kind of very ancient disease, mentioned in very ancient civilizations. So what we can take from this microorganism, or the tuberculous bacilli, able to resist to some extent, and if left untreated, uncontrolled, definitely we might end up in one day facing a strain of this bacteria that we cannot control, no longer control. Only about 1/3 people with drug resistance, unfortunately, seek treatment, and that will reflect how serious this antibiotic resistance can be, unless, again, we find a way to address this issue and to tackle it in a right way, in a right strategy. Globally, TB incidence is falling in a rate of roughly 2% per year, and that's make the average drop in the TB cases between the year of 2015 to 2020 less than 11%. That's unfortunately still short than the plan by the WHO to drop or to reduce the cases or to control the disease by at least 20% by the end of the year of 2020. All of these bad news, I think we can just spice it up with one at least bright news here, that an estimated 66 million lives were saved through the TB diagnosis and treatment between the year of 2000 to 2020. One of the key problems facing controlling the TB globally would be financing issues, and basically setting TB in as a priority for governments as well as for the communities. So it's very expensive, definitely, as a disease. It costs the community a lot of kind of a big budget of the health planning. In addition, also it affects the community directly and indirectly by affecting the working force in the community as well. So roughly it's estimated that $13 billion needed every year for TB programs, TB prevention, diagnosis, treatment, and care, to achieve the goal of reducing the cases or the number of TB somewhere around or eliminating the disease by the year of 2030. Unfortunately, as I just mentioned earlier, that we have a bulk of the cases in certain countries. Nine countries are where most of the cases, or at least 2/3 of the cases. These countries, unfortunately, are still not putting TB as one of their major priorities, and their spending in government budget is still way short, less than 41% of the expected goals or expected participation in TB elimination program. Still, there's a hope, and the international community, represented by the WHO and the World Health Organization and the United Nations, still hoping to at least control the disease or eliminate the TB by the year of 2030. So who's most at risk? I think important question, since we just mentioned TB is everywhere. It can be in all 5 continents. Mainly the most affected adult in their most productive years, but definitely all age groups are at risk for diabetes. For TB. People who are infected with HIV are 18 times more likely to develop active TB. High-risk persons suffering from other conditions that impair their immune system, and that by itself can be another problem that can affect the ability of the body to fight the latent TB, especially. People with undernutrition are 3 times more to develop TB, and unfortunately, by the year of 2020, there were 1.9 million new TB cases that were attributable to undernutrition. The TB transmission, as we all know, person-to-person contact, air transmission, through coughing and sneezing, spit as well. One of the key things also we need to remember here, the bacterial load or the required bacterial load to develop the disease is very low. So that means only few germs can cause the infection. Unfortunately, it turned out based on statistics, almost 1/3 of the world population had a latent TB, meaning that previous exposure and possibility of dormant mycobacterium in their body, which possibly can be reactivated later in life. Another kind of problem with the TB, that in active TB disease, the symptoms may be mild for many months, and that's by itself a problem, because mild symptoms means the patient less likely to seek any medical treatment, and during this time of developing the symptoms until the patient take the disease seriously, definitely that means a lot of spread or direct person-to-person transmission. And it turned out that one person can infect between 10 to 15 other people through close contact over the course almost in 1 year. Just brief introduction to a TB pathology. Primary tuberculosis due to inhalation, direct inhalation, usually present with subpleural granuloma, as we all remember, and then the development of hilar lymph nodes, and these two together here, the subpleural granuloma with the hilar lymph nodes, or known as the Gans complex. In nearly all cases, these granuloma resolve, and there is no further spread of the infection, and then possibly can either become completely eliminated or transform to dormant infection or latent TB. The second form of disease, which is secondary tuberculosis, seen mostly in adults as a result of reactivation of the latent TB, or possibly also reinfection. As a patient immune system get weaker, the latent mycobacterium can become active, and this will result in a form of miliary TB, and that result in dissemination. And now the disease, besides infecting the respiratory system, can also disseminate throughout the body, infecting the skeletal system, causing osteomyelitis, and the very common form of osteomyelitis, or TB osteomyelitis, to infect the lumbar vertebrae, and we all remember the Potts disease. Genital tract tuberculosis also can cause salpingitis in female, both salpingitis and endometriitis in female, and definitely that comes with a risk of infertility. In male also can cause epididymitis. UTI, TB, we all remember the sterile biuria, which is urine sample showing white blood cells with negative routine bacterial culture. CNS infection or disseminated TB can cause meningitis, and the most common finding in TB meningitis would be the cerebrospinal fluid or spinal tap, which shows high protein, low glucose, and lymphocytosis on the cerebrospinal fluid. Fortunately, that the gastrointestinal form become very less common nowadays, and that's a form caused by the Mycobacterium bovis. Adrenal infection of the disease also, as a result of this dissemination, can lead to complete destruction of the adrenal cortex, causing different forms of endocrine disorders, including Addison disease. Scrofol can happen also, especially in children, where the tuberculous lymphadenitis of the cervical lymph nodes, which also can produce a mass that is firm, matted nodes just under the mandible. Cardiac TB, also as a result of this dissemination, can lead to pericarditis, and that pericarditis also can be more complicated with hemorrhage, can also later complicated by fibrosis and calcification, and that at the end possibly can cause constrictive pericarditis, and that by itself can later progress to heart failure, as we all know. Comparing TB in the US as screening management, and my attempt is to compare the treatment or the current treatment in the States or developed countries versus developing countries, for example, in Africa or Asia. TB statistics here in the United States, patient of the age of 60, older than 65, account for almost 25% of the active cases in the US, and that by itself is definitely a red flag. Geriatric population more susceptible to TB more than young adult in the United States or most of the developed countries. In long-term care residents, prevalence of skin test reactivity can range between 30 to 50% due to high rate of exposure in the early 90s. That by itself can reflect in two ways. First, foremost, it possibly can affect the accuracy of the screening mechanism, which I will explain on the upcoming slide. Number two, that the reactivation by itself definitely put these patients or this particular age group in a very high risk problem, since they are already dealing with other health challenges. Most active cases in older adult are due to reactivation based on the statistics. Very few, slim possibility to find a case of TB or active case in TB here of TB in the United States due to primary infection, but still a possibility there. Risk factors in the United States or developed countries: gastrectomy, body weight less than 10% below ideal, and this by itself very common, as we all can understand, in the geriatric population, possible with the possibility of malnutrition or undernutrition or nourished. Chronic kidney failure, also very common in geriatric population, and definitely make the group more susceptible to secondary or reactivation of TB. Diabetes by itself, immunosuppression, including the caused by corticosteroids or medically induced immunosuppressive, but due to the treatment of, for example, multiple sclerosis or rheumatoid, the use of corticosteroids very common among this population as well. Tuberculosis skin test, the PPD, induration, or as we all remember, this is a type of type 4 hypersensitivity reaction. We call it delay type hypersensitivity as well. That is the only type of hypersensitivity reaction based or being under the control of cell-mediated immunity. Induration or injection of the purified protein derivative units, roughly around 5 units. Then we read the result after 48 to 72 hours. Induration 15 millimeters or more, that's a positive test in all situations. Induration less than 15 but larger than 10 millimeters is considered positive in certain population or certain groups that include nursing home residents. Recent converters, meaning that patient had an induration less than 5 millimeters, and then you have to repeat the skin test later, as we will mention this in a minute, as well as immigrants with the induration more than 10 millimeters, and underserved US population, especially in poor neighborhoods or poor communities, Prisoners as well can fit under this category here, as well as the risk factors, or people with the risk factor I just mentioned in the previous slide. Induration for more than 5 millimeters is considered positive in specific conditions, your specific criteria, HIV infected patient, someone with close contact with people with active TB as well, and definitely having induration more than 5 millimeter with the chest radiography showing any evidence of the disease. Definitely we can consider that as positive test as well. And most of the especially in long-term care facilities, should use the two-step procedure for PPD testing during the initial evaluation of residents. And that means 2 steps of PPD test require retesting of a patient with less than 10 millimeters in duration within 2 weeks. So if it turn out to be positive or to shows in duration greater than 10, definitely that means it's this test is positive. Management in the States versus management in the developing countries. Treatment of active cases, which we will cover in details in the coming slide. But can you make sure to mute your microphone, guys? Thank you. Regardless of the age, anyone with a positive BB skin test should be treated with isoniazid for 9 months, and that's if they have never been treated in the past for active TB or active disease itself had been excluded. Treatment, medical treatment for positive cases rely on multi-drug combination, and mainly 4 drugs therapy, including isoniazid, rifampin, pyrazinamide, and 8-1-bitol or the streptomycin. These 4 medications require 4 antibiotics require the initial treatment, then usually taper to 2 or 3 drugs regimen to follow. The most common regimen would be isoniazid, rifampin, and pyrazinamide for 2 months, then followed by isoniazid, rifampin for additional 4 months. That make the full treatment period of 6 months. Now we have to keep in mind here the most common side effects of some of these medications, especially the peripheral neuropathy that can be prevented by the use of pyridoxine, as well as hepatitis, due to the hepatotoxicity of isoniazid, rifampin, and pyrazinamide. DOTS, it's a good kind of means to apply a simple concept of healthcare using less expensive tools and engaging the whole community, meaning that engaging a local community as national communities, as international communities, in a collaborative attempt to target or to tackle TB in the developing countries. The DOTS itself, with the program, stand for Directly Observed Treatment Short Course. The goal of the program is to treat positive TB cases, and the positivity or the criteria to select positive cases is a positive sputum smear positive. Those it's internationally recommended strategy for TB control that has been recognized as a highly efficient and costly effective strategy adopted by the WHO to treat TB in developing countries. The 5 elements of DOTS: political commitment, and that's mainly come for financial support, as well as logistics and legislative decisions to support the program. Case detection through a quality assured bacteriology, standardized treatment with a supervision and patient support, and effective drug supplement, and definitely monitoring and evaluation of the system with definitely a need to intervene if there is any weakness or defect appear in the system. The first component, political commitment, and mainly to foster national and international partnership with the local as well as the international community. Local partnerships, especially with the contributors, will help to improve, for first and foremost, access to communities, because as we all know, TB still kind of fit under the taboos over certain diseases in communities. People won't accept the fact they're affected by the disease, or even feel ashamed to seek treatment, or at least to admit the disease in the family. So having a local partnership in their local communities will give the provider at least access to the community. Local partnership, also a partnership with the community, is also important for equity, to ensure that everyone in that local community have full access to the program, or at least to the treatment, as well as to ensure the quality. Also, to ensure the availability of adequate and competent human resources, since you're going to work in the communities, definitely you will not have volunteers, or at least the workers in the program, to be from the community, and that will save definitely. And when it comes to the expense of running such international program in the big countries, especially in the developed countries or developing countries. Political commitment also should be backed by national legislation, and that's important to allow the program itself to reach the community. The second component will be the case detection through quality assured bacteriology, and using a certain criteria in this case, which is to identify positive cases by using a sputum smear, and then basically identifying the organism in the sputum smear. Definitely that require a wide network of properly equipped laboratories, and definitely well-trained personnels. And then every country should have a full functioning national reference laboratory for for quality assurance, as well as for training. The third component of the DOTS, standardized treatment with a supervision and patient support. As I just mentioned earlier, that the treatment itself for active cases, it's a long-term treatment, at least 6-month course. The medications, as we all know, comes with different side effects. Among these, the neuropathy that we just mentioned, as well as hepatotoxicity. So to basically make sure that patient stick to the treatment, this is where this part of the DOTS basically make it a little bit more effective means to control the disease in local communities, because you're not only offering the treatment or the access to the treatment, as much as also full support to the patient and direct supervision of the patient taking, or at least consuming their required medications. So to facilitate adherence to the treatment and to reduce the risk of development of drug resistance, the importance of having a supervised treatment with full support, direct observation of the therapy through well-trained personnel, treatment supporters from the community, which by itself is important, because having a supporter from the community will at least break some of the barriers between the patient and the healthcare workers, and that will help at least the patient to stick to the treatment. Locally appropriated measures to identify and address physical, financial, social, and cultural barriers. As we just mentioned, this disease most common in developing countries. Trying to isolate someone from engage in the community. That person is supposed to stay home, let's say, for at least 3 weeks of the active cases of TB at the very beginning of the treatment. That can be hard for people who work day to day to support their living. So definitely financial support and communication also, or at least commuting can be an issue also in such communities. So finding a way to facilitate their patient commute with the treatment centers to follow up, as well as to get their monthly treatment, or at least a supply. That's another essential component of this program. Beside that, also the cultural barriers in these communities. So finding a way to educate people about the TB. TB is a treatable disease. Find a way to basically attract more patients to the treatment centers. That's also part of this program. Effective drug supply and management system to definitely uninterrupted and sustained treatment supply to the patient is a key for the program to succeed. Also, reliable system of obtaining and distributing all essential anti-tuberculous medication to all relevant health facilities at the very same time. You don't want to run in shortage. You don't want a patient start taking at least half of the medication, not taking the other half, since we mentioned the antibiotic resistance and the possibility of this microorganism to even develop more mutations. And that drug, anti-tuberculous drugs, should be available free of charge. And just to ensure that by itself can be a challenge, especially in developing countries, as we all know. Possibility of corruption, possibility of people try to take advantage of this, assuming this is a free money coming from WHO, and just charge patient for this, and that's what comes definitely with expense of people might end up unable to afford the treatment, and the problem will get indeed worse. The fifth component here would be the monitoring and evaluation of the system with different level of coordination, the regions, as well as district, national coordination, as well as international, and then a mechanism to evaluate the progress and finding ways to fix any problems as soon as they appear. So this kind of just a brief presentation about the TB and the DOTS program. So just feel free, guys, if you have any questions, to share it in the chat or to unmute your microphone.
Thank you, Dr. Mohammed, for the great presentation. If anyone had any question or any comment, please unmute yourself and go ahead.
Thank you so much, Dr. Mohammed. This is also a great presentation and very informative. It's an important topic, and hopefully we will use this information in the future. As when you start the residency, you will see some patients, and you need to know some of the basics for treatment of TB. But thank you so much. Any other questions, guys? If no more questions, maybe we can go to the next section. Thank you both, Dr. Osama and Dr. Mohammed, for the great presentations and hard work and effort. Thanks for sharing.
Who's presenting next?
Yeah, just 1 second. Yeah. I'm preparing for. Yeah, the next presentation will be history of Framingham heart study. Will be presented by Azza Abu Bakr. So I will share her the screen, and she will now she can unmute herself and start.
Hello everyone, Ramadan Kareem, and hope you have Ramadan Mubarak for you and your families. Today I will talk about, can you hear me? I don't know. Yes. All right. So today I will start, before I can talk about Dr. Dauber, let me just give you a brief about what is the Framingham study and what is the Framingham heart study. This is actually a study that have been going on for 7 decades. The study is also is under the direction of the National Heart, Lung and Blood Institute. Why they started this study? Because we know that cardiovascular disease is the leading cause of death in the United States. So at the year of 1948, as I said, the Framingham Heart Study has been started, and it's a project just to know what are the major risk factors for cardiovascular disease. They recruited more than 5,000 men and women from the ages of 30 to 62 from the town of Framingham at Massachusetts. Those subjects who had not yet developed an overt symptoms of cardiovascular disease or suffered any heart attack or stroke. So then, since that time, the study have been going on since 1948. They began as an original cohort. As I said, those were the 5,000 men and women from the town of Framingham. They have also added a second cohort, which is called the Offspring Cohort. Those are the sons and daughters of the original cohorts. And also they added something called Omni cohorts in 1994. They also, I will explain those later, and a third generation cohort in 2002, and new Offspring spouse cohort in 2003, and the second generation Omni cohort in also 2003. So this has been a massive study for over like 3 generations. So over the years, they have been able to monitor the subjects of the study. They also identify the major cardiovascular risk factors like blood pressure, blood triglyceride, the cholesterol level effect of and the age and the effect of gender and psychosocial issues. The risk factor for others physiological conditions also has been identified, such as dementia. So in addition, the relationship between the physical traits and genetic patterns also have been studied. As I said, there were 6 groups of participants in the Framingham study. The original cohort, the Offspring, the Omni Generation 1 cohort, third generation cohort, new Offspring, spouse cohort, and Omni Generation 2 cohort. So as I said, the Offspring cohort was initiated in 1971. So they need to establish a prospective epidemiological study of the young adult. So those are as I said, the kids of the original cohort. The Omni cohort 1 was started in 1994. They need to reflect the diversity of the community. So they started to include African Americans, Hispanic, Asians, Indians, Pacific Islanders, Native Americans. So that time, those were like consist about 10% of the study population. The Omni Cohort 2 was started also just to expand the Omni Cohort 1. So they included more of the more ethnically diverse group, as I said. They included many individuals related to the participants of the Omni Cohort 1, relatives to the Omni Cohort 1, and also individuals unrelated to those. So the generation 3 cohort, those are the third generation of the original cohort. Like I said, they have included their son, now they are including their grandsons. During the offspring, the enrollment and examination of a third generation of participants, which will provide a greater resources of the phenotypic and genotypic information. The new offspring cohort, those consented and completed the exam of the generation 3. They can be the offspring of that generation can be included in another cohort, which they call the new offspring cohort. So those are the major 6 cohorts that have been going in the study of more than 7 decades. Now, this is the timeline of the study. As I said, it started in 1948, and it's still, I think it's still going on, the study. And they have been able to identify one of the major cardiovascular risk factors over these years by following the original cohorts and their offsprings and their spouses as well. Okay, next. So while pursuing the study, established research goals, the National Heart and Lung Institute and the Framingham investigators are expanding their research into other areas, such as the role of the genetic factors in cardiovascular. As we know, now they have like a massive genetic information. They have been following the dads and the granddads, so they have a huge library, so they can study the genetic effects in cardiovascular disease. One project underway will utilize the genetic material from immortalized cell lines of all of the cohorts. The Framingham investigator also collaborate with the leading researchers from around the country and throughout the world on the projects in stroke, dementia, osteoporosis, arthritis, nutrition, diabetes, eye disease, hearing disorders, lung disease, and genetic patterns of common diseases. So now I'm going to talk about Dr. Dauber. He has also initiated and maintained the Framingham Heart Study, and he worked in the study for over 5 decades. They are saying about him, and they have a tribute to him in their website. He directed the study from 1949 to 1966. He allowed the Framingham study investigators to pursue their interests, no matter how unorthodox they might seem. This resulted in the Framingham investigators correcting many important misconceptions that physicians had about heart and lung vessels and heart and blood vessel disease and its predisposing risk factors. So the scientific reports produced during his time have alerted the physicians to the ominous implications of atrial fibrillation, left ventricular hypertrophy, small amount of albumin in the urine, systolic hypertension, the arterial rigidity, the obesity, the high cholesterol. These and other early findings have made the Framingham study reports among the most cited references in the medical literature. These findings also made the Framingham study a prototype for other epidemiological studies around the world and established the utility of the risk factor concept for gaining valuable insight into development and prevention of chronic diseases. So thank you, everyone. This is brief about the Framingham Heart Study. I hope you benefited from this. And about Dr. Dauber, if you have any question, just feel free to unmute yourself.
Thank you so much, Dr. Azza, and this is also a great concise presentation about the Framingham study. And I think you might have an idea about it when you study for step 2 or maybe step 3, but we don't know some of the details of how they started this project and the importance of that, how it can affect many aspects in medicine. So I just want to share with you that it was a simple idea that they want to get the cohort from one place, and they convince all these people in that place, and then they followed them up. They do regular examination, they do survey, they ask them questions on a regular basis. They do some examination like labs, X-rays, CTs, and then they follow them, and the data is available for all researchers to dig in and see if there is any correlation between this and that and so forth. So it's a helpful approach to major problems, and the collaboration is important. So maybe one day you will come up with some ideas in the research area, and if you start with some collaboration, you may end up with a big project similar to the study, Framingham study. So much, guys. Thank you, Azza.
Exactly. Thank you, Dr. Mather.
Any comments? No questions, no comments. All right. Go next. We can talk about next section then.
Okay, thank you, Dr. Muhammad, Dr. Azza, for great presentation. The next topic is one of the Framingham Heart Association studies. This is one of the recent study done by Framingham Heart Study participant, because they have a collection of data for couple of thousand of patients, you can say, and here is analysis of one of the studies. So I'm going through this one. It is let me share my screen. Here's a study. Is walking is good, but moderate vigorous exercise boosts fitness 3 times more. So the study is done by Matthew Nair and his team. The topic is physical activity and fitness in the community, Framingham Heart Study. Introduction. Greater routine physical activity is associated with lower cardiovascular risk and improved longevity. In 2018, physical activity guidelines for American encourage several types of physical activities. These include dedicated exercise, moderate vigorous exercise, lower level of activities such as step or walking, just walking, and minimum activity or of sedentary time, or called SED. In the present investigation, we related different type of physical activity with component of cardiovascular fitness. In 2070 participants from Framingham Heart Association. Our relative large sample permitted assessment of how vigorous combination of sedentary time, step day, and moderate vigorous physical activity were related to cardiovascular fitness, as well as enabling examination of how relationship of physical activity and fitness measures varied across age, sex, and cardiovascular risk factor or risk status. The aim of the study, while greater activity, physical activity is associated with improved health outcome, the direct link between distinct component of physical activity, their changes over time, and cardiorespiratory fitness are incompletely understood. So we need more study or meta-analysis in this kind of study, especially walking and exercise. Matthew Nair and his team at Boston University School of Medicine set out the answer in largest study to date aimed at understanding the relationship between regular physical activity and person physical fitness. Questions addressed in the study. First, we wonder how different intensity of physical activity might lead to improvement in body response. And we expected to find that higher amount of moderate vigorous physical activity like exercise would lead to better peak exercise performance. But we were surprised to see that higher intensity activity was also more efficient than walking. And we were also uncertain whether the number of steps per day or less time spent sedentary would truly impact peak fitness level. And we found that they were associated with higher fitness level in our group, in our study group. The second question is that we asked, how do different combination of 3 activities measures contribute to peak fitness? And we observed that individuals with higher than average step by day and moderate vigorous activity, exercise activity, had higher than average fitness level. And the third question was, are more recent physical activity habit more important than previous exercise habit in determining current level of fitness? This is a question. Interestingly, we found that participants with high activity value at one assessment and low value at another assessment had equivalent level of fitness, whether or not the high value coincided with the fitness testing. And this suggests that there may be memory effect of previous physical activity on current level of fitness. Method of the study: maximum effort cardiopulmonary exercise testing, or CPET, and objective physical activity measures, sedentary time, set, step day, and moderate vigorous exercise, MVBA, via accelerometer work for 1 week concurrent with CBET, and 7.8 years prior obtained in 2,700 Framingham heart study participants. Their ages varies from 54 plus or minus 9 years. 51% of them are women. Sedentary is 810 plus 83 minutes per day for characterized of sedentary lifestyle. And step day is 7,737 plus or minus 3,520. And for the moderate vigorous physical activity, it is like 22.3 plus or minus 20 minutes per day. And the peak oxygen uptake is VO2 is measured of 23.6 plus or minus 6.9 mil per kg per minute. This term is important in this study. So findings were largely consistent across categories of age, sex, obesity, and cardiovascular risk. Increase of 17 minutes of moderate vigorous physical activity per day. It's like 95% confident interval, or 4,312 steps by day, or 95% confident interval, or reduction in 249 minutes of sedentary life per day. It will give like 95% confident interval. Between the two exam cycle correspond to 5%. And the higher peak of oxygen uptake in this people is the main measure or main cornerstone of the assessment. So individual with high above mean step or moderate vigorous physical activity demonstrate above average peak oxygen uptake value, regardless of whether they had high or low sedentary life. The result of the study, after reviewing variable distribution for normality, peak oxygen uptake at voluntary aerobic threshold, VAT, and moderate vigorous physical activity were naturally algorithmically transformed, and oxygen uptake recovery delay was square root transformed prior to analysis to reduce the squaredness of this variable. All cardiopulmonary exercise testing and physical activity variable were mean centered and standardized prior to analysis. We evaluate the cross-sectional association of CBET dependent variable with physical activity measures using multivariable linear regression models adjusted to age, sex, location, which is New England, average merit of activity, monitor wear for step and moderate vigorous physical activity, body mass index, resting systolic blood pressure, hypertension, smoking, diabetes, and prevalence of cardiovascular disease. We put all these measures in our consideration in this study. So the result here, if we see oxygen uptake kinetics or late exercise or peak exercise and exercise recovery or oxygen half time, we see that it was increase. If you see here, the estimated beta coefficient, which represent the changes of standardized cardiopulmonary exercise testing. So we will find that it will be increasing from sedentary time to step by step to which can reach the peak in moderate vigorous exercise. So the main idea here is when we go from sedentary lifestyle to moderate vigorous exercise, everything is increasing. That means oxygen uptake is increasing, oxygen uptake half time is increasing, exercise recovery is increasing, and the mean response time also increasing. In this diagram, we found that physical activity variable, if we see the red line correspond to moderate vigorous exercise, which reached 27 point something, and step by step is almost like 25, and for sedentary time it is 2.5. So when you go up, the increased oxygen uptake will be increased, and it will reach the peak on vigorous exercise. So relative association of physical activity measures with cardiopulmonary fitness, peak oxygen uptake, overlaid added variable plot and are displayed for association of a standardized log and standardized step by day log and moderate vigorous physical activities and sedentary time. Each line was fitted individually, adjusting for age, sex, cohort, season of device wear, and location, New England, average minutes of device wear, body mass index, resting blood pressure, hypertension, medication use, smoking, diabetes, and prevalence of cardiovascular disease. So here is Framingham Heart Association. The number of patients is 2,070. If we see here from left to right, in the rest, you will see the oxygen uptake reach here, this level. In early moderate exercise, it will increase. In late exercise, it reaches the peak of exercise is here, the green line. So whenever you go from resting to late vigorous exercise, everything is increasing and the fitness will be increased. So the cardiopulmonary testing exercise is measured by oxygen uptake. So here we have the two questions. How do we measure of routine physical activity related to physical measures of cardiovascular fitness? And this is represented by the peak exercise here and the peak of oxygen uptake on this axis. And the second question is that, are changes in physical activity over time linked to high cardiopulmonary fitness? And if we see here from initiation, early moderate exercise, late exercise, peak and recovery. If you go from sedentary life step by step to moderate vigorous exercise, you can see that every time you go to the right, everything is increasing. So the vigorous moderate exercise have high oxygen uptake and more cardiopulmonary fitness. So the principal finding of our study or NIAR study are threefold. First, moderate vigorous physical activity had the highest effect size for exercise response pattern throughout exercise relative to total step a day and sedentary time. Second, we observe linearity in association of physical activity or physical measures and peak oxygen uptake and broader consistency of association among categories of age, sex, obesity, cardiovascular status, and so on. The third principle is the relationship of steps and moderate vigorous physical activity with peak oxygen uptake was additive, such that the highest the peak of oxygen uptake was observed in individuals with higher value for both moderate vigorous physical activity and step a day activities. Interestingly, higher activity level, both moderate to vigorous and total activity by step a day, were associated with greater than average fitness level, regardless of the amount of sedentary time. Peak oxygen uptake is considered the gold standard measures of cardiorespiratory fitness and is closely related to health outcome across the entire spectrum of health and disease. Importantly, moderate vigorous physical activity was linearly related to peak oxygen uptake, indicating that while the guidelines recommended that threshold is more than 150 minutes per week of moderate vigorous physical activity, is 22.4 minutes, may be reasonable benchmark and closely approximate mean of moderate physical activity level of 156 minutes per week observed in our cohort. So in this study, we will find that the moderate vigorous physical activity even was higher level of moderate vigorous physical activity would be expected to result in continued improvement in physical activity fitness with more than 3 to more than 14-fold greater efficiency in achieving higher fitness level than moderate walking or reducing sedentary time. So that means moderate vigorous physical activity is more fit, give you more fitness than step-by-step or sedentary lifetime reduction. These associations are consistent with among categories of age, sex, BMI, cardiovascular status, reinforcing the message that physical activity is associated with higher level of fitness across age and health status. In addition to peak oxygen uptake, we observe association of physical measures with numerous cardiopulmonary exercise testing variable reflecting oxygen uptake during initiation, moderate level exercise, late exercise, and peak exercise and recovery. That is mean global cardiopulmonary fitness peak is closely related to the changes in physical activities over time. So if you increase from moderate exercise to vigorous exercise, you will get benefit more than with moderate exercise or minimum or even sedentary times. Individual with persistently low activity level or high sedentary time had lower cardiovascular or cardiopulmonary or cardiorespiratory fitness. So our findings suggest that cumulative exposure to physical activity may be related to long-term fitness level. In conclusion, lower sedentary time and greater step day and moderate vigorous physical activity and their change over time were each associated with better cardiorespiratory fitness measures. The highest effect estimated was observed for moderate vigorous physical activity, which was associated with favorable cardiopulmonary exercise testing fitness measures throughout various intensity level of incremental exercise. These findings are consistent with the notion that different form of physical activity, especially moderate vigorous physical activity, are associated with cardiopulmonary or cardiorespiratory fitness in general public, regardless of one age, sex, BMI, or cardiovascular status. Interestingly, we found that participants with higher activity value at one assessment and low value at another assessment, and perform 8 years apart had equivalent level of fitness. Whether or not the high value coincide with the fitness testing. This suggests that there may be memory effect of previous physical activity on current level of fitness. Thank you.
Thank you so much, Dr. Osama, for picking up this article and discussing it. I think it's an important aspect also when we talk to our patients or our family, or even when we go around in our own lives. So I think exercise is important. I think it's beneficial. So the more you exercise, the better your health is. So thank you for picking up this and sharing this article. Excellent. Very informative. Thank you.
You're welcome. Any
So-
question or any comment?
So for the next section, maybe we can talk about it later.
Yes, one question to Osama, if you don't mind.
Yeah, go ahead.
Yes, this is very good and informative presentation. I would like to ask, this vigorous exercise is also like advised to, as you said, regardless the age and sex and underlying cardiovascular condition. Is that also for any underlying medical conditions? That I mean that people can do that vigorous exercise regardless their conditions, or can be having adjustment for this exercise, the time and the strength of the exercise.
Yeah, actually, it would be adjusted for every patient, but here in this study, they just consider the information that they have, because this is a collection data from Framingham Heart Association or Heart Association study. So they have a pool of data, and they use this data for this study, but they use it for AIDS and some cardiovascular disease and some other medical problems like hypertension and so on. So, but it doesn't cover everything. But I think it should be adjusted according to the patient fitness or a patient toleration.
Okay, thank you so much.
Welcome.
Thank you so much. I think we can go to the next section. We plan to discuss about how to improve or change or edit the CV or resume or the application. If you want, we can discuss that today if people are ready and wants to continue. We already spent the 2 hours. We can prolong the meeting, or we can just set the agenda for next week and then we can discuss this topic next week.
I think we can move this topic for the next week because no one prepared this topic for now.
Right.
So it could be discussed by next week.
So we can add that to the agenda for next week. And
Okay.
speaking about agenda, maybe we can talk about the next week agenda. So it's gonna be the, I think,
The verbal team.
verbal team. Okay, Dr. Mazin, your team will present some topic about syncope, maybe improving network, how to connect with others, and get some help maybe from previous residents, fellows, program directors or program coordinators, or
Mhm.
and then maybe someone can talk, Dr. Kurba or someone else can talk about the research gate, and we can leave the misconduct. We can talk about how to improve the research, the resume or the CV of the application.
Okay, sounds good.
Any addition, anything else from you or your team or attendees? Anyone wants to discuss certain topics or anything?
We gotta discuss this thing like on the group, and I'm gonna post like who's gonna present which is which in the website.
Sounds good.
Okay,
Thank you.
of course.
Thank you everyone for attending the meeting. Thank you for participation, and thank you for your presentations. This is great Zoom meeting, and I wish you all the best. Again, كل سنة وانتم طيبين، رمضان كريم. ربنا يتقبل. Allah accept from all of us. I wish you all the best. Have a wonderful day. Have a wonderful evening or night, whatever you are. Thank you. We'll see you next week, inshallah.
Thank you so much, Dr. Nader.
Thank you. Thank you, everyone.
Thank you so much. Thank you, everyone.
Nader, thank you.
Assalamu alaikum.
Thank you.
Thank you.
Thank you so much.